absolutely, truly delighted to open this session tonight for us here in Australia, but today in the European region. I am Professor Bodil Rasmussen, and I'm in the School of Nursing and Midwifery at Deakin University here in Melbourne in Australia. And I am here opening with a good colleague, Janet Anderson, Professor Janet Anderson, who is a professor in human factors at the Department of Anesthesiology and Perioperative Medicine at the Faculty of Medicine, Nursing and Health Science at Monash University. Before we go into the business of tonight and the lecture, I would like to acknowledge the country and welcome to the country as we gather here for this meeting, physically dispersed and virtually constructed. Let us just take a moment to reflect on the meaning of place, and in doing so, recognize the various traditional lands on which we do our business today. We acknowledge the elders past, present, and emerging in all the land we work and live on, and the anesthesiological spirit with gratitude and respect. So thank you. I would hand it over to Janet for a short introduction.
Thanks, Bodil. Welcome to everybody. It's wonderful to see so many people joining the webinar, and we are extremely grateful to Jill for giving us her time and her expertise. I just wanted to say a few words about human factors. As Bodil said, I'm Professor of Human Factors at Monash University, and I study the quality and safety of healthcare by looking at factors that maybe are often neglected when we're thinking about the quality and safety of care. So things like teamwork, communication, decision-making, problem-solving, workflow and processes, and even the design of equipment and spaces to make sure that people can work together effectively and safely. And it's often those system factors that are neglected. If we design the system very well, then we're likely to optimize the safety of both patients and staff and increase efficiency. So that's the kind of focus of my research. And I just wanted to highlight that we have put together a short course on human factors for healthcare professionals. We think it's really important that healthcare professionals have some understanding of this perspective so that they can have a much better understanding of the latent safety threats that are inherent in every healthcare system and become much more aware of it. So we have this online short course, which Gary has helpfully posted in the chat. There's a link to it there. It's a totally online course which runs for 7 weeks. And we're planning at this moment to build on that with postgraduate qualification degrees, grad dips and master's degree. So if you're interested, please have a look. And then the other thing that I just wanted to highlight is that Jill has agreed for us to record the webinar, which we will upload to our website in due course. And Gary will post a link to that at the end of the webinar. But just at the moment, I will hand back to Bodil to introduce Jill.
Yes, thank you, Janet. And it's very much a delight to introduce Jill Maben. Jill Maben is professor at University of Surrey in the UK, and she's professor of health service research at the nursing department. And she has worked for many years around nursing and healthcare research in seeking to understand staff well-being and patients' experience at both national and international levels. And tonight we are focusing on unprofessional behaviour, which obviously attracts quite a lot of people since we are that many on the link. So the unprofessional behaviour between staff that encompass the various behaviour. So we will be interested to hear more about that and the specific acute care in the settings and disproportional impact of minorizing staff. So While this intervention have been implemented and migrated to unprofessional behaviour, there's limited understanding to how and why and why it may work and for whom. So we are looking forward to your presentation, Jill, to go into depth on these issues. Thank you very much.
So thank you for that very generous welcome, and thank you for having me this evening. I'm absolutely delighted to be here. Obviously, it's early morning here in the UK and the sun is shining. Yeah, I'm looking forward to sharing this important research with you, which we finished at the end of last year. So as Janet and Bodil have said, looking at a study, a National Institute of Health Research study that addressed unprofessional behaviours between healthcare staff. And I'm going to share with you the evidence we found from our realist synthesis, our recommendations and next steps. So do contact me if you've got any extra questions or need anything from me. My email is there. So this was our project team. It was a multi-centre project led by me at the University of Surrey. You will see a colleague from Australia there, from Macquarie University, and I'm going to come back to some of her work, Joanna Westbrook's work, who some of you may be familiar with. What I'm going to talk about today is I'm going to give you some background. Why is this a problem? What's been going on? The methodology we used, the drivers or causes of unprofessional behaviour, and interventions and strategies that we have gleaned from the literature and grouped together. And then we've developed a guide to unprofessional behaviours, addressing unprofessional behaviours between healthcare staff. I have a hard copy here. Oops. And I've asked colleagues to put that in the chat. I think because I'm not host, I can't post that. So if you could post the link to our website, you can download the guide. But I think there's also a QR code coming up. So thank you. Then we'll have some time for questions and answers. And I think if you post the question and answers in the Q&A part, not the chat, then we'll be able to see them. So what's the problem here and how has it been defined? So unprofessional behaviours we have defined as any interpersonal behaviour by staff that causes distress or harm to other staff in the healthcare workplace. And we did that because there's quite a lot in the literature around bullying specifically, some around incivility, less around other types of behaviour, interpersonal behaviour, and certainly less around, for example, sexual harassment and so on, which I'll come on to. But we do know these behaviours impact patient safety and staff wellbeing. And we are focused on behaviours between staff in this project, not staff towards patients or patients towards staff, although that we know is a growing problem as well. So I'm presenting findings today from this National Institute of Health Research funded realist review, and these were used to build the guide, as I've said, which I'm going to present towards the end. So what's the problem? So here's some recent data from our National Health Service staff survey and the Workforce Race Equality Standard data, which shows the extent of bullying and harassment, 19% by colleagues and 11% by managers, and a disproportionate amount directed towards or experienced by Black and minority ethnic staff. What wasn't really in the literature and is not asked about in our NHS staff survey, and we don't have the equivalent of a race equality standards, we don't have gender equality standards, is issues around sexual harassment and assault. So last year, a colleague at Surrey did a survey of NHS surgeons reported here in The Guardian, which suggests nearly 1 in 3 female NHS surgeons had been sexually assaulted. And only last week was this Nursing Times piece, which talked about 1 in 10 NHS workers were experiencing sexual harassment and demanding further action to protect staff. One of the colleagues in our stakeholder group was Mary Lawson from Deakin from the medical school, and she was definitely able to tell us that this is a growing problem in Australia as well. So in terms of the drivers, many factors obviously contribute to unprofessional behaviours, but the focus on the literature has largely been on individuals, this idea of sort of bad apples needing to be weeded out, for example. And we wanted to go beyond this. We wanted to understand what are the mechanisms through which these contributors work, these drivers, How do these factors manifest and interact to worsen the impact of unprofessional behaviour? And we had this paper published in BMC Health Services Research, and hopefully that QR code will work. Very happy for the slides to be sent round as well as the recording, so you can peruse this at your leisure at a later time. And in terms of interventions, the UK has a range of activities implemented in practice to address unprofessional behaviours, but these aren't well understood. And unfortunately, although there's some relatively small, particularly work around incivility, there's no published examples of evaluations of these interventions from the UK. Many more from the US and from Australia, which I'm going to come on to, but we don't have good evidence from the UK of what works in terms of intervention, because there's lots of slightly fragmented piecemeal activities going on that we don't really know about, because they're not fully evaluated and they're not written up and published. So we had to ask, therefore, what interventions are going on worldwide to address this issue. And this review looking at interventions has been published in BMC Medicine. Again, the QR code there. So you can have a look at that at your leisure. So our methodology, we did this work between October 21, in the middle of the pandemic, and 2023. Luckily, it was mostly desk-based work, so that was possible to continue. And we did this realist review, drawing on 148 sources from healthcare settings like the UK, so like Australia, New Zealand, United States, Canada, for example, and including 42 reports of interventions in acute care settings worldwide. That was the total amount that we had in our data set as of December 2022. And what we did was we drew the findings together to create theories of how and why interventions work. So why did we use realist methods? So I've been using realist evaluation and realist synthesis methods for a number of years now, and I have to say they do get beyond the surface and get to enable theorizing really well in a way that I would suggest other methods haven't. And they definitely go beyond this idea of, does it work? Is it effective? And ask why and how does it work and for whom does it work? And context is everything in this, as you can see from the little cartoon. You know, you can implement the same intervention in one setting and it works well, and in another it doesn't. And so how and why interventions should work are often poorly understood, explained in healthcare. And unpacking this enhanced our knowledge of how interventions can be improved. The other thing to say about realist reviews, unlike a systematic review, is that almost all literature counts, because you're trying to understand the problem and how it might work, the mechanisms. You actually can use quite a lot of the background of a paper. You can use papers that are editorials and opinion pieces, because they can give you great insights, or as Ray Paulson would call, golden nuggets of insights. And it's really interesting to help you understand much better. So I would recommend anyone thinking of wanting to know a little bit more to consider realist methods. You've got some great methodologists in Australia on this. So what did we do? For those of you who like to see the design, here's what we did. So in a realist review, you start with building initial program theories, as they're called. So we drew on the literature in our proposal, the literature we scoped for writing to get the grant, and we did some informal literature searching. So you start with a small bundle of literature, and you build these initial program theories. We had stakeholder group input throughout. That included patients, public, voices, but also experts by experience of staff, people who had experienced bullying and harassment, incivility, microaggressions, for example. So we had that, as you can see in the green boxes, throughout. The next step is to search for evidence and construct a systematic search and do this purposive literature searching that I've talked about. And then you're constantly testing between the evidence you find and your initial program theory. So it's a back and forth iterative process. And those steps 3, 4, and 5, and 6 may be repeated again and again with more searching if you don't feel you're getting enough data, or you think there's another area to explore, as we had to go outside of the UK for interventions, for example. And then you form what's called CMOCs, context mechanism outcome constructs, that are really heuristics to help you understand how the context influences mechanisms to fire and to generate their outcomes. So that's what we did in a nutshell. So going to the drivers of unprofessional behaviour with contributors, in terms of the context that may allow mechanisms to fire and to contribute to mechanisms, is this workplace disempowerment, harmful workplace processes and culture, lack of manager awareness and urgency, a reduced ability to speak up, and inhibited social cohesion. And the mechanisms are an increased likelihood for staff to engage in unprofessional behaviours, the reduced ability for staff to cope and to report, challenge or address them. And outcomes, there's just a few here, there could be more, but would include an increased presence of unprofessional behaviours, reduced patient safety, impact staff wellbeing and poor quality care and experience at the distal end. Before that would be many, many more steps to get there. And the drivers of unprofessional behaviour paper is at the bottom of this slide again. In the UK, we have something called Freedom to Speak Up Guardians that came out of the Robert Francis report or scandal in the UK. And they were introduced to allow people to speak up, thinking about this reduced ability to speak up. And what was striking about that was that they were put in place as a result of Robert Francis' work, really to drive patient safety and quality. So there's an expectation that staff would be reporting patient safety and quality issues to Freedom to Speak Up Guardians, who may try and resolve it or take it to the board or take it on, support people to speak up. What was striking was that in the first couple of years, all those, not all, but over half of the reports to Freedom to Speak Up Guardians were about bullying and harassment. So that was a big surprise, and it told us something, that actually people were not able to speak up and there was nowhere else to take these. People had often exhausted HR processes and other processes and organisations, so they were going to the Freedom to Speak Up Guardian often as a last resort, and that was a big surprise because that was not what they were set up to do. And that I did a national evaluation of Freedom to Speak Up Guardians in 2015 to 2017. And so that got me into this work, just as a background of how I came to be studying this, when mostly I'm looking at staff wellbeing in my work, but also, as we know, this causes stress, anxiety and poor psychological health, which may cause people to leave organisations. So very much ties in with my other work. So this is a very busy slide and I can't possibly go through it all today, but it's how we've tried to theorise and put some of these ideas together. So unpacking the workplace disempowerment, and these M's that you can see there, they're numbered mechanisms, the inhibited social cohesion, so the context elements I talked about in the last slide, and then the mechanisms are here. So I won't dwell on this very long. It is in our drivers of unprofessional behaviour paper. And as I say, you can have a look at these slides at another date, because there's too much detail to go through here, but I just wanted to put it here to kind of illustrate how realist thinking works, but also some of the detail of the work. So moving on to interventions and strategies. What do we mean by these? So these are our definitions. So we've talked about interventions as coordinated sets of activities. So activities sit within interventions to change specified behaviour patterns. They might comprise the means of delivering strategies. So are they written materials, lectures, psychological techniques, role play, whatever, the strategies themselves, and the evaluation methods assessing their effectiveness. So that's the whole package of interventions. And strategies are the active ingredients within interventions that try to change behaviour in specific ways. And interventions usually include several strategies. So these are the sorts of types of interventions we saw across the literature. So were they single session, multi-session? Were they sessions with an add-on, like looking for accountability, a code of conduct, for example, and whether something broader like a structured culture change. As I said earlier, and I'll come on to that in a minute, a lot of the interventions, or most, were focused on individuals rather than the structured culture change. And going back to the Freedom to Speak Up Guardians work, as part of their role, they have culture change in their remit. But our evaluation found a huge variation in how these roles are implemented, with some each organisation was responsible for setting it up themselves and funding it. So some organisations might have 1 day a week of somebody being a Freedom to Speak Up Guardian alongside a clinical role. So it was quite an add-on. Often the clinical work took precedence. And others might have full-time Freedom to Speak Up Guardian. Equally, those people could be newly qualified practitioners, allied health practitioners, nurses, or they might have been somebody who has used to speaking at board level, used to navigating the complexities of a healthcare organisation, such as a former HR director. We found one of those as a Speak Up Guardian. And you could imagine that their ability to speak to the board, even have the ear of the board, not everybody reported to the board, made the effectiveness of that role very, very different. And so if you didn't have much time in your role as a Freedom to Speak Up Guardian, that element of structured cultural change fell by the wayside. You were literally firefighting all these Freedom to Speak Up requests that came in. So very, very different implementation. So what we talked about in our guide is we've made a distinction between what we've called quick wins and long-term interventions. So we know that we've tried to aim the guide at different people in different settings, and people like ward managers or team leaders who may want to do something. And I think our big message is it's essential to do something and to role model doing something and be seen to do something. And so these quick wins might be strategies that respond to incidents and raise awareness among individual and team members. So there might be session-based interventions, or posters, or something about incivility, or some bystander work, for example. And then we also wanted to talk to those who might get some resource. So maybe the organisational development team, HR, whoever it is in organisations, your organisation who is likely to be able to take this forward, to have these longer term, more resource intensive interventions that could potentially make widespread culture change, and that work across organisations and systems, and where there's perhaps issues around professional accountability, structured cultural change, so something bigger and broader. So you'll see in the guide that there's these different elements. Also, there's some long-term interventions with evidence of effectiveness, as I said, not in the UK. And one is the civility, respect and engagement in the workplace, CREW, which is at the Veterans Hospital in the US. And in this example, there's an emphasis on responsiveness. So you might, there's lots of different elements to it, and you might pick which you do and in which order, but the idea is to conduct a survey to understand more about the problem, how and why unprofessional behaviours are taking place, ring-fence dedicated staff time for improving civility, and then depending on the survey findings, implement a range of flexible strategies. And I'm going to come back to flexible or more structured interventions and some of the pros and cons and challenges of that. Others are professional accountability programs, Vanderbilt and Ethos, for example, and it is Ethos that has been implemented in Australia, and I'm going to come on to that in a minute. So this draws on what's called an escalating professional accountability pyramid with reporting, that has a reporting system, a peer messenger system, and training. So it's very tailored to different types of unprofessional behaviour and different types of incidents. So for single incidents, there might be informal conversations. Where data reveal patterns, there might be a non-punitive awareness raising intervention. And where patterns persist, there might be something like a leader developed action plans. And if the action plan fails, then the disciplinary process. So you can see that it's going from a very informal, slowly up to a more formal disciplinary process. And certainly in some healthcare systems, and I would argue probably in the UK, we often end up on the right-hand side of this slide far too quickly. We often end up in disciplinary processes for some of the most minor misdemeanors that could have been solved informally and could have been dealt with more readily. So coming on to that case study of the ethos intervention, I thought this may be of interest to potentially a largely Australian audience. So since 2017, the Ethos Professional Accountability Programme has been implemented in 8 hospitals in Australia. And the aim is to foster a positive culture change, reduce unprofessional behaviours and improve speaking up. And it draws on a reporting system where you report not only negative behaviours, but also positive behaviours. Peer messengers who would deliver this. So there's a reporting system and it's reviewed by peer messengers. There's a group of staff who would look at the issues coming in, would review them, and then there were dedicated peer messengers who would go and talk to the person who has been reported either for negative or positive behaviours and go and speak to them. There's an ethos accountability pathway and there's training involved, as I showed on the last slide, different scale of development of process. It's aimed at both clinical and non-clinical staff, and my colleague Professor Joanna Westbrook led this evaluation team over 5 years, and there is one of her recent papers. There's another one came out last week as well, so do have a look for that. Just got some data from the ethos intervention here because I thought it may be of interest. So in terms of never experiencing civility in the last 12 months, pre-ethos, the 6.4, only 6.4 of respondents suggested that they had never experienced incivility in the last 12 months. And post-ethos, that had gone up to 11.8. And then in terms of reporting behaviours, weekly to multiple times daily, pre-ethos, that was 41.7, and post-ethos, that had dropped to 35.5. So I think we can see some effectiveness here of ethos, that it is making a difference. So you can see in the chart here, in the blue, yes, staff never experiencing bullying, that's the pre-ethos, and then staff reporting behaviours weekly to multiple times daily, that's the two bits of data point I've just read out. And I have to say that there were some extreme behaviours reported in this ethos work, physical assault, demands for sexual favour, sexual harassment, sexual assault, and in this evaluation, they also saw that these additional 5 extreme behaviours significantly declined. So going back to what strategies are available and work, for whom, in what circumstances, we identified many strategies and we collapsed them into what we've 13 types. And usually, as I've said earlier, an intervention draws upon multiple strategies. So sometimes it's hard to say whether individual strategies on their own work because they're part of a bigger gestalt. And those we identified are just those that exist so far. There's plenty more to be developed. I mean, this is such, in presenting this work, there's clearly an appetite for this, which is rather sad to say because there's clearly a big problem in our healthcare systems, but there's more innovation to come, I'm sure. And in the guide, what we did was we matched strategies with the contributors so that practitioners can address unprofessional behaviours. And on the right of this slide, you can see some of these different strategies. So it might be improving awareness, improving ability to cope, direct approach to the instigator, as in something like the ethos programme, social norm setting, improving teamwork, some of these broader culture change things that might make a difference, improving leadership competence, and then the sort of understanding the prevalence and implementing strategies and some of the external pressures on organisations to do some of these things or not to. That, you know, the focus on productivity can sometimes come in the way of some of these culture change issues. So I wanted to give you an example here. So, and there's many more examples in the guide. So, for example, I want to tackle workplace disempowerment and improve staff members' ability to cope or speak up. So what you might theorize that you want to do is improve the confidence to come forward and improve awareness and knowledge. So here are some different elements that might improve confidence to come forward. one would hope in the UK, the Freedom to Speak Up Guardian would be one of those, but assertiveness training, role-playing, cognitive rehearsal, keeping records, and then improving awareness would be an education type intervention, lectures to improve understanding. And this can be a quick way to address unprofessional behaviours, although it's often insufficient on its own. It's no good only raising consciousness and of what are unprofessional behaviours and how many are going on in the organisation. Still need to do something else often to tackle it. But it can be a foundation for future work and other intervention content. We also identified 7 key principles to enhance intervention design. We've identified patterns across interventions that could impact success, and we called these key principles. There's 12 in our report and 7 in the guide. Our report is a big 50,000 word NIHR report, which should be coming out any day and will be put on our website when it's been published. But in the guide, we've shared some of these 7, as I've said. And in the guide, as I've said earlier, we've also got suggestions of implementation principles, but also arrange them as quick wins or longer term solutions, so that it's a sort of a bit of a pick and mix depending on what resource you have and time. So going through some of these principles, as I've said already, we found quite a lot in the literature about it being a focus on individual conduct, but interventions must also address systemic factors, because we all work in the system and in the bigger context. So you can't just target bad apples and think that that's just going to change everything. And so organisations do often focus on bad apples rather than systemic issues. But we also need to enhance psychological safety to foster an environment where it's safe to speak up. My colleague Russell Mannion has written a great paper about bad apples, talking also about bad barrels and bad orchards. So actually that it's not just the bad apples, the individuals, you can have bad barrels, teams, and bad orchards, organisations. Encouraging bystanders to intervene helps drive culture change, but may cause moral injury. So this encouraging versus not encouraging sort of dilemma or dynamic that we found in the literature, encouraging staff to intervene definitely sends the message that unprofessional behaviours are no longer tolerated, but it may put staff at risk of reprisal, or they may have experienced moral injury where they can't make a difference and they go away with regrets, or it's not an opportunity where they can intervene or speak up and be a good ally and active bystander. So encouraging people to do it and then they feel they can't can present dilemmas and moral distress and injury. But not encouraging staff to intervene can imply that managers or the organisation is not serious about addressing unprofessional behaviours, and is probably something to be avoided. But then that would enable people not to feel that they've ought to speak up and experience moral distress, perhaps. Authenticity helps build trust in management and leadership. So we found quite a bit about, we unpacked this issue about authentic interventions versus them being perceived as inauthentic and tick box. So when management seems committed to addressing unprofessional behaviours, staff are more likely to give interventions a chance. But when managers continue to exhibit or tolerate unprofessional behaviours, or the intervention appears like a tick box exercise, staff are unlikely to engage. So it's all very well about giving us these interventions, but what about the behaviour of X, our manager, or so on, or the leadership of the whole organisation? You know, there's a disconnect that staff experience, understandably. It's crucial to address the behaviour of senior staff, therefore. And if managers don't hold themselves accountable, staff are unlikely to engage. So this builds on the previous point. And an intervention needs to include or target managers to be seen as fair and authentic. One of the challenges of that, however, is if you have managers in a group session or in a training, it can make it not feel safe to speak up, and staff may not feel they have psychological safety. So there's a tension there too. And interventions definitely need to be inclusive and fair. Going back to the beginning of the slides, we know that women and ethnic minority staff are targeted more than others. So some groups are disadvantaged and require specific help in this area. And interventions should include all groups to be perceived as fair and equal. there was quite a dilemma in the literature about whether you should focus on these groups because they needed more help, but actually by targeting those groups, it could feel unfair, they could feel targeted, and others could feel left out, and it could cause more tension. So there's quite some interesting debates in the literature about that. I alluded to this earlier, a flexible intervention can be successful, but it's hard to evaluate. So some of the programs like Vanderbilt has built-in flexibility that can be really good for different contexts and depending on what you find. But if it's very flexible, it can enhance effectiveness, but be difficult to evaluate because it's not replicable and there's lots of different elements to it. And it might be not hard to know which bit has influence that any change you see. And keeping the intervention content fixed can actually enhance the ability to evaluate what works, but a one-size-fits-all may not be great. So there's lots of tensions and dynamics here that to unpack. And interventions to reduce unprofessional behaviours can also enhance speaking up. That's definitely part of the same milieu and trajectory here, and enhance staff wellbeing and patient safety. All that was absolutely what we would hope. And enabling speaking up, online systems like in some of those programs I talked about, Vanderbilt, Ethos, can enable staff to speak up safely, but may not prevent harm in the moment. So you can see here that, you know, in the operating theatre, if somebody's about to remove the wrong kidney, but it's a reporting online system to make it psychologically safe, that's not going to save the kidney. So whereas if staff feel able to challenge an error in the moment, this can prevent patient harm in a different way. So there are pros and cons there of online reporting systems. Does that anonymity and that ability to report in that way, is that helpful? Can be for many things, but actually may not prevent all harms. So our final program theory is here. So the intervention designs are on the left here. Again, a lot on this slide. I don't expect you to read it all, but it is in our papers and will be in our report. Selecting the strategies, thinking about these key dynamics that affect the intervention success, some of which I've presented. There's 12 in the report. There's a few more here, like ensuring no group of staff feel left behind or singled out. I mentioned encouraging bystander intervention, but only when it's safe. And then if an intervention is successful, we might have positive outcomes. And if unsuccessful, it can spiral and you can get a vicious circle of unprofessional behaviours that can really reduce patient safety and increase poor wellbeing, and staff can leave, and you've got a bit of a mess on your hands, and further loss of trust in management. So we came up with some elements to enable intervention success distilled from the literature. So about presenting clear messaging, assessing the organisational culture, using multiple interventions and strategies. It's unlikely that only one on its own would work. Make sure that the intervention is just and not overly punitive. Maximise the visibility of actions, but not so that it's a tick box exercise. Encourage allyship. Identify and nurture leaders who are emotionally intelligent and understand these issues, and there's a compassionate leadership program in the UK, for example. Harness existing organisational processes, so use meetings and formats and places to introduce this work. It doesn't always have to be an add-on, and if possible, harness existing organisational teams like organisational development teams, etc. And involve staff in co-creating interventions. We didn't see much of that in the literature, but there was definitely quite a lot of staff knowing what was needed often and how they might go about it, and that voice was often unheard. And the appointment of dedicated staff definitely enabled success. So having some resource and people who were visible, who could go to, who were seen to be leading this was quite critical. So just a few areas to focus on in future interventions. You know, we think maybe some more drawing on behavioural science. How is this supposed to work? Why are the strategies going to lead to our desired outcomes? What are the assumptions about how this will work? What other contextual factors might impact success? In realist evaluation, what you're trying to do particularly when you're looking at interventions and evaluating them, is trying to get in the mindset of the intervention developers, because it's not always explicit. So there will be some theorizing in most interventions about, if we do X, Y will happen, and this will result in a Z outcomes. But the why how you get from if we do this to this will happen is often not explicit at all. And certainly the behavioural science and why that might be happening is very hidden. But in realist work, you are trying to get into the minds, or trying to understand what the intention of the intervention developer was, and how they might have theorized that doing X would produce Y. So it's another way of getting underneath the surface of evaluation. We know there's an undue burden on women, ethnic minority and disabled staff. New staff, shift workers and agency workers are also particularly affected. And this should be acknowledged, and interventions designed to address this. There was not much visibility, and certainly in our stakeholder groups, we had a particular spotlight session on Black and minority ethnic staff. And we talked about who was doing the research, who was writing the papers, why there was not much visibility around this. And of course, there's wider societal racism that feeds into all of these points. When developing the interventions, evaluate and report learning so others can benefit. This goes back to our slight frustration that we found out rather serendipitously how much was going on in practice, but because we were doing a realist synthesis and literature review, we did not see that in the literature, so couldn't write about it and evaluate it. We did invite people to speak at our webinar, which is also on our website, about an instability program, so you can see that there. So that was something of a frustration, but I know often these things are done on a shoestring, and there isn't always the evaluation expertise in organisations. So this is our guide. I think I showed you a hard copy. It's available on the website. Hopefully the link is also now in the Q&A or the chat, so you can see that. You'll see that when you come to download it, there are 2 or 3 short questions. Where in the world are you? Why do you want to use this? What's your role? And could you give us your email address? And that's because in universities and as academics and the sorts of work we do, we're trying to measure, we have to measure impact. We get evaluated on, has our work had impact? And we don't always know that when we produce work like this and it goes out into the wider world. So what we would like to do is just know reach, where it's gone. And then if you're willing to give us your email address, we may contact you in 6 months or 12 months. Don't worry, we won't harass you, but say, have you used this? Was it useful? How would you want to change it? And did you give it to someone else? So I would ask you not to try and pass on PDFs, because then we're not measuring reach and how many people are downloading it and where it's going. But that's just a caveat and an explanation about why we're asking that very short questionnaire. The guidance gives some brief overview of contributors, general points to be aware of, strategies that have been used. It's got the case study of the ethos intervention in there, building on intervention, so the quick wins and long-term solutions that I've talked about, and these key principles are all in there. That's where you can get the guide. Hopefully the link is also in the chat. There's a QR code there, and you will be getting these slides. We worked with a designer and an illustrator to try and make the guide easy to read, accessible and useful. So any feedback would be much appreciated. And then finding out more, there's details of our funding award here. We wrote a protocol outlining the methodology and what we did. Here's some of our papers. And as I've said, the final NIHR will be published soon. So that was everything I wanted to say. Thank you so much for your attention. And I'm going to stop sharing now and hand over to Bodil and Janet. Thank you.
Thank you so much, Jill. That's been fabulous deep dive into the whole world of unprofessional behaviour and exactly what's needed, rather than a superficial approach to such a difficult problem. Really fascinating. Can I just, we've got a couple of questions, but can I just start with a question from me? I'm just really interested in the way your work has highlighted the fact that the whole system seems to be designed to elicit this kind of behaviour. You know, we're getting more and more pressure, we're getting more and more staff moving in and out of facilities, people not knowing each other and so on. And obviously that's because of a system under a lot of pressure.
Yeah.
And so given all of this pressure, how do you think organisations can target an intervention to the particular problems in their organisation? Do you have any thoughts about that? Or just to add a piggyback question, or are there some things that you can say every organisation should be doing as a base, you know, as a baseline?
Definitely. I think there's things every organisation should be doing. One is paying attention to this. Two is doing something about it, whether it's doing quick wins or funding a longer term programme. I don't know whether the Ethos programme will now be more rolled out or adopted in Australia as a part of Joanna's work, for example. But there is much work to be done here, and we've pointed out some of the tensions and some of the challenges, but it's definitely do something. This is not going to go away without us doing something. We know that some of these behaviours are probably increasing in society, and organisations are sort of microcosms of society, and sometimes because of the high intensity and the type of work that's done in there, that can be a sort of pressure cooker for some of these behaviours. And some people have got away with some behaviours for a long time, and some organisations have done nothing for a long time. And the culture is not a place where it's good to work. And that gets known, and so it's a vicious circle, and that, you know, organisations need to pay attention to that. It's very similar with the other work I do around staff wellbeing, where, you know, the increase on productivity, we've got very bad staff shortages in the UK, we've got strikes. It's a vicious circle, and actually the less you pay attention to staff wellbeing and things like unprofessional behaviours, the more you're creating this vicious circle of staff leaving, staff shortages, more pressure. The productivity question is not going to go away, and the demand is not going to go away. So it's giving it attention, I think, and you know, if there are resources, appointing dedicated leaders and having a programme.
Thank you. I'll just draw on some of this because we've got quite a few questions now. One question: how is unprofessional behaviour best measured at the unit or department level so we can track improvement?
Yeah, great question. I mean, there's quite a lot of tools for measuring this. I mean, there's some certainly in our own NHS staff survey that asks, you know, have you experienced any of these behaviours? And so you're tracking over time to see numbers and reach and how much is going on. I think, you know, a lot of those programmes like Vanderbilt, Ethos, Crew have as at their core understanding the problem first. So they all have tools in there to try and ask these questions and understand. First of all, you've got to understand before you can act. And then, yeah, so there are, I mean, I guess there's issues around questionnaire fatigue, but if it's built into regular surveys that come out anyway, rather than, I mean, we know in other instances that like staff engagement, if you keep asking staff about staff engagement and then do nothing, it's worse than doing nothing. You can't keep asking people about things and then not acting. So if you're going to measure and find out about these behaviours, you really then want to have a programme of action. Otherwise, staff will turn off and think it's all lip service and it's going to be tick box and why am I engaging?
Sure. I've got another question here from somebody who's involved in workshops involving role play scenarios to give feedback to, you know, somebody about their behaviour. But what can be done about somebody who seems to lack insight or even the ability to kind of understand that it's a problem? Is there a way that you can get past that?
Really difficult, isn't it? I think we've probably all been in role play scenarios or training where that's happening, or you know, people who should be in the training and aren't there. And you know, it's a real challenge. And I think some of the programs, and I think some of the peer messenger programs that really try and hold a mirror up to people can be very helpful for that. It's not being escalated. It's your colleague having a quiet word. It's your colleague saying, you know, when you do this, that results in that. So holding up a mirror is not an easy work. We wouldn't all want to do it, and we wouldn't all be capable of doing it. But it's so important that actually you're having these behaviours pointed out, and the lack of insight pointed out. But you will win some, and you will definitely lose some, as we know. It's human nature. But yeah, I don't know if that really answers the question, but I think it's identifying that that's an issue, and so there may be more consciousness raising. It may result in another training intervention or peer messenger type work, or, you know, a quiet word, or some other intervention after that. That's gathering more data, isn't it? We'd see people in our organisation who don't have insight. That's what you would conclude from that. So what do we do about that?
Sure. There's a couple of questions about the ethos study, and you know, I was going to ask about that as well. I mean, they did have significant results, but they were fairly modest over that time frame. When you're trying to change such a huge organisation, I suppose the questions are really about how sustainable that a program like that is, and how long it might take to actually get really substantial change, if we know.
Yeah, I suspect Joanna would be able to speak much more eloquently about this, but from what I know of the programme, and I guess any programme that's really trying to achieve culture change, is we know we're in challenging territory. Shifting the dial in culture is hugely challenging and hugely difficult, and you may get pockets where it's worked, where there's been sustainability, and pockets in an organisation where it's fallen away, and that can be something as simple as staff leaving, a rotation of staff. You know, if you've got a champion who leaves, then that can be really problematic. And we saw that in another evaluation I did, looking at the evaluation of Schwartz Rounds, which I know you also have in Australia now, where the sustainability, and also in that the responsibility on people's shoulders on top of the day job, was difficult to keep going and sustaining. So you know, it comes back to resourcing.
Yeah.
So really giving people time to do this work, people having leadership roles associated with it. Great to have Joanna's team and the resources of an evaluation to kickstart this and get it going. It will, as you say, be interesting to see how this sustains over the long time, and that would be the same with many interventions. And I guess the other thing to say is that we know in healthcare there's always the new thing, the new intervention, the new flavour of the month. And I think sometimes great interventions and great programs of work fall away because the next new thing comes along. It doesn't mean the last thing wasn't good or wasn't having effect. It's just someone else, a new CEO or a new manager, decides we're doing something different and doesn't always know the organisational history. And I know that can be deeply frustrating for staff and us all, because it happens in universities too.
Yeah, I couldn't agree more. I think there's also a sense that things should work quickly, and if they're not, then they're not going to work ever. So yeah, get rid of them.
We know that's not true.
Yeah.
We know this sort of work takes a long time. It's not overnight. So whilst you're describing what happened in Ethos as modest, the fact that they saw any significant change, I would say, is a huge success, because this is not easy work, particularly in this sort of topic and this sort of field.
Absolutely. There's an interesting question here about evaluation methods. When you have a kind of multifaceted intervention that's flexible, what kind of methods could organisations use to evaluate success or otherwise?
Yeah, I mean, again, you know, challenging work, and as we said, because you're people leave, and people who maybe had the training leave, and you don't know what other things are going on in your healthcare system that might have affected change. It's always really difficult, and we can't do a randomized controlled trial, or not very often, and have a control group. So I'm a great fan of qualitative methods, but we would have survey data, and there are the tools, as I've said before, to measure. So in terms of evaluation, you would want to capture evaluation data about the individual program elements, and put that together. For example, in Ethos, you would want to talk to peer messengers. You want to talk to those who received the peer messages, the messages, and, you know, what did that do in terms of behaviour? How was that received? So there's so many ways to evaluate it, of course. And whether you focus on individual teams or a directorate or an organisation, you know, is really down to your resource, and are you trying to have a quick win? And I guess that's what we see in the NHS, people trying to do something and have quick wins, which is great, but lacking either the resources or the skills to do the evaluation, which I guess is where us as academics come in. But then we need to get funding, and luckily Joanna did for the Ethos programme, but we've now put in funding. It's our next steps to try and test this guide in the NHS and test the principles anyway. And we're going with some organisations who've got some history of doing work in this area and some who haven't. So that's literally just gone in. So watch this space. We've also got another project just gone in about employee voice. So a bit more about the speaking up, how it's heard, how it's not heard, often not heard, certainly no action. So yeah, watch this space. We hope to do some more work in this area.
Thank you. Maybe we've got time for one more question. There's a couple of questions about the role of leaders and managers who particularly might not have specialised training for those roles. And how do you encourage them to step up and kind of respond when there is unprofessional behaviour?
Really challenging. I mean, all this work is mired in the complexity of human behaviour, let's put it that way. And some people will be open to that and want to do that and get it, and others may have had to have a personal experience to fully understand it. But I guess it comes back to this: who are you targeting your training at? Are you going to start at the top? Are you going to start with managers? Because they're so critical. We know people often leave managers, not organisations. So that they have a fundamental role. But we also know they're the massive jam in this sandwich of sort of edicts from above and lots of pressure and then complaints from below. And so, middle managers are hugely stressed and overloaded. So it's difficult to put all the responsibility at their feet. And in a way, this is everyone's business. If we want to make it a good place to work, it's all of our business, which is why allyship and bystander behaviour and all of these different elements together will hopefully shift the dial and result in some successful change.
Okay, thank you. Well, I think we're just about out of time, although there are some questions that I haven't addressed, and apologies for that we weren't able to fit in everything. Can I just say huge thanks to you, Jill. We so much appreciate you making the time, especially so early in the morning, to speak so coherently and passionately and persuasively to us. It's been fabulous. Thank you.
Thank you. Thank you for the invitation.
And can I just remind people that there is the link in the chat to your guide. There's a link to our website where the recording will be in due course, but that may take a couple of weeks to come through, but we will post that.
Right. And I'm happy to make the slides available. So let me know if you need a PDF or you can send the slides you've got.
Yeah.
I'm happy to.
We'll definitely do that. Thank you so much. And thank you to everybody who attended, and good night or good morning.
Thank you.
Thank you.